Dr. Rebekah Lemmons has served in the nonprofit, academic, and related sectors for mental health and rehabilitation since 2010. She has added to the profession by publishing research, engaging as an adjunct professor, serving on professional executive boards, and working as a nonprofit leader at the local and national levels. Rebekah is passionate about improving outcomes for those at risk and underserved clients by elevating standards of care and service quality. Dr. Lemmons, we're so incredibly honored to have you join us here today. And at this point, the floor is yours.
Thank you so much. It is an absolute honor to be here today with you all. I appreciate ARCA for the ability to host these webinars and to elevate voices around disability, mental health, and related concerns. That's going to be a key topic for today is really engaging in an overview of perinatal mental health, which is more of an emerging field, even within the mental health community itself. And not a lot of attention has been given to these issues historically. So, elevating those voices and perspectives is going to be critical for today. What I will do now is share my screen so that you guys can see PowerPoint. So, you should be able to see that first PowerPoint screen. And so, as reminders, as Daniel mentioned, you can use the chat. We'll have a few different activities interwoven today just so that you guys can break up a little bit of the learning. And if we need to go over any questions at that point in time up to date, we can also do that as well as at the end. And at the end, I'll have some slides with my contact information. I'll go over a resource slide just so that you guys have some takeaways if that's something that you would like. And if there are more specific trainings or questions that you have and that you want to know, you can also put that in the comments to that survey that is sent out as well so that we know, how to best target and get you guys the information that you would like to have related to this and other topics. So, as Daniel mentioned, I'm excited to be with you guys today. I have a background in what I call more integrative approaches to mental health. So I love, things and initiatives that come with being a CRC in rehabilitation counseling and holistic care. I love to pair that with yoga. I have a background and I'm a registered yoga teacher, as well as different things related to perinatal mental health and other aspects of general mental health. So excited to speak on that a little bit today. And you'll hear a blend of a lot of those things and approaches in the way that I approach some of these issues. All right. So, in terms of what we're going to do today, Daniel's mentioned the continuing education pieces as well as the initial introduction and welcome. And today is going to be an overview where we blend perinatal mental health and key core components along with some of those disability related considerations. So, we will go through an overview of perinatal mental health in general at the high level. And then we will get into how does disability interact with that and fit into this topic. We will then move forward into other areas of policy, research, some legislation, just so that you guys have a high level context and overview of some of those things going on within the profession and within that specific area. Most of those policies will be from within the United States, but we'll give a few examples of some other policies in other countries just for context as well. All right. So, in terms of the objectives for today, those are listed out on the screen. And again, feel free to use whether that's that chat or some of our engaging opportunities, because based on your role, your scope, your current credentials, and some of your experiences, you may have questions on certain areas compared to other areas. You also may have insights in areas of expertise where you can add to perspectives, add to the discussion, or maybe even give some really great examples of either your work with this population or some thoughts with your disability expertise. And so we welcome that as well. If you have a strong story or example that you think could help others, please type that in the chat or hold that for that discussion time. And we would love to hear from you because we have so many really great, strong folks on this call and members of ARCA that we can all learn from each other. All right. So, one of the first areas that we think about when you say perinatal mental health would be, well, what is perinatal mental health? In terms of perinatal mental health, this is the mental health of both what we call the birthing person and the non birthing parent. So, this time period is what's also critical about when you hear perinatal mental health for a time period specific to this population that is from pregnancy through 1 year after birth. So, most people would say it's essentially pregnancy up until the child's first birthday, and that would be the perinatal period. And perinatal health, again, would be related to the mental health during that time period of all of the parents involved in that specific situation. We are going to go over some key terms in a little bit just so that you'll have some context of the different language that individuals use when they talk about this population. And we'll also talk through some guidelines. Those guidelines for best practices in care will really help you with recommendations, screenings and assessments if appropriate, and also having a high level understanding of some of those key training components. What's also important is to think through the aim of perinatal mental health work, education, and intervention is to thoroughly support the emotional and the well being of parents and children. And that's by increasing positive attachments and interactions. I want to make a note specifically, though, that this is inclusive to all parents because there are many caregivers throughout this process that could have perinatal mental health issues, concerns, disorders, or needs, and may not initially be a target of a screener or mental health intervention because they might not be the birthing person or the individual who is pregnant at that time. But this is inclusive to all different types of parents and caregivers because other parents and caregivers can also experience issues related to perinatal mental health during this time. So, also just a note as we're about to move into key terms, you will see, depending on your setting, depending on the literature that you're reviewing, or some of the information and education and trainings, you may see and hear a few key terms that are used interchangeably. And that's okay. So, for example, you might hear terms like caregiver or parent. You may hear birthing, non birthing parent. You may also hear support persons. And some of those, again, are just going to be used interchangeably throughout research, but we're going to go into some key terms today to give you context on some of the ones that would be potentially most helpful or that you're going to see most often. So, in terms of these key terms listed here, when we think about a birthing person, this is anyone who gives birth, and this is regardless of their gender identity. So, this is more gender neutral and inclusive than prior terms like mothering, fathering, maternal, paternal. And so that's why we want to highlight that specific term of birthing person. Now, one key term that's not listed on this slide specifically, but that you may also want to make a note of if you are going to be interacting with some of these clients is pregnant parent. And this is a more inclusive term compared to pregnant woman. So by history, we would say pregnant woman. And now that most inclusive term is going to be pregnant parent. So that's that more gender neutral and inclusive term. In terms of non-birthing parent, so that is going to be more inclusive compared to the term father. Now, some research studies who are done on really specific areas and populations, you're still going to see the term father, you're going to see the term dad. And for this, we just wanted you guys to have those updated inclusive terms for everybody on this roster. So, in terms of this, again, that's that reminder that non birthing parent may also be referred to as a support person to the pregnant parent or the birthing person. That may be when you hear support person, it's that primary other co parent. And sometimes support person can be somebody additional. Maybe support person is some other family member or a professional support. So, it doesn't have to be the non-birthing parent, but oftentimes when you hear support person, it is the non-birthing parent or person who is also there with the most interaction. So, parent and caregiver, when you hear about that specific to perinatal mental health, these are just more inclusive terms and replacements for that mother father term. But this also covers different types of families and caregivers because sometimes parents and caregivers range, whether that's grandparents, whether that's adoptive parents, whether that's a birth parent, whether that's a foster parent. And so that just gives you some inclusive language to really help as you dig deep into what's appropriate for the specific client that you're serving. Chest feeding is another inclusive term compared to breastfeeding that is more gender neutral. And of course, many of you guys are familiar with persons with disabilities. And so that general term as well. Again, just making a note and remembering though that based on your setting, you might see an array of terms. So often you're going to see some terms related to this in pediatrician or pediatric offices. You're going to see some terms related to this, of course, in hospitals or OBGYN offices. You're going to see some of these terms related to mental health service providers and offices, and they may use different terms when they're talking about these same key areas. As a note for myself, I find that it's always really important to ask the specific person and client what terms they prefer, just as a best practice, as a way to be individual focused and person centered, and because different people are going to prefer different terms at different times. And so we want to be respectful of that dynamic in the counseling relationship. I have included some other key terms here just for some additional context as
Yo
well.
también, momentito. Y
Oh,
era un señor mayor, sí.
Oh, thank you. Looks like that was just a mute situation. Okay. I wanted to make sure we weren't missing an important question there. So, in terms of these additional key terms, we are focusing on that perinatal period, which again is pregnancy through the first year after birth. It's also important to know these terms because many individuals hear more of these terms compared to perinatal. So, until I really got into perinatal health and education, so within the last few years, I had always heard more of these terms. So, for example, prenatal or antenatal, and that's during pregnancy. So, when people talk about prenatal care, sometimes that's a more common term. Or I had heard about postpartum and postnatal. That is in reference to the first year after giving birth. So, those terms are a little bit more common. You're more likely to hear those or have clients bring up terms related to that for you. Some terms that are more specific, though, to the perinatal period in that area of work is this PMADS term. So you'll hear that a lot throughout the presentation. And what PMADS is perinatal mood and anxiety disorders. So I want to make sure that we delve into the fact that that includes not only your mood disorders, your disorders such as depression, bipolar, psychosis, anxiety disorders. You also want to think through that would include generalized anxiety disorder, panic, obsessive compulsive disorder, and disorders like PTSD, for example. Now, these are going to be specific to that perinatal period. So, think if somebody's in their pregnancy period or throughout that first year, then it's going to have that perinatal onset or emphasis as well as you're thinking through those. But those general disorders, many individuals who are already familiar with mental health work have kind of a base understanding of those. For perinatal specific issues and what that looks like and differences, there are some really great videos if depending on your learning style through PSI. So that's also on here. PSI that we're going to talk about is what's called Postpartum Support International. And PSI is an association that, again, until I was learning more about perinatal mental health, I hadn't really heard of before. But they are an association who puts on conferences. They help to develop examination criteria for individuals who want to be certified. That's that next key term as a perinatal mental health certified specialist. So, someone who is trained in perinatal mental health and certified in that. And PSI has some good videos on YouTube that give you very specific examples and manifestations of each one of these perinatal mood and anxiety disorders. They also have some really specific examples of individuals with lived experience on these issues so that you can hear from the client's perspective what that was like, what their experience with this was. And so those are some different resources that are available as well. Now, some things that I also like to call out is some things like, for example, when you're talking about perinatal mental health and psychosis. That's rare in terms of a perinatal mood and anxiety disorder to have something like psychosis occur, but even though that's rare, I do call that out because it's really serious when it occurs. So that can occur with all of the different brain changes throughout pregnancy, which is also why it's not unheard of to develop, issues related to depression or some symptomology of some of these other perinatal mood and anxiety disorders, because there are so many different changes within hormones, within physical issues, within brain structures, and a host of everything else that comes with that specific period. So I did want to call that out because that's why it's so important that people have at least an understanding of this education, or even support individuals and persons are aware of some of these impacts of mental health that could occur, because in those situations it's going to be critical that that support person is really making sure that we've gotten inpatient care or 911 are really called to get some help if there's something that's seriously going on, particularly right after that birthing time. So, some other things that we'll talk a little bit about today is this perinatal mood and anxiety disorder term that you'll hear throughout is more of a shift compared to what people used to say related to just postpartum depression. So, a lot of people have done really great work to gain exposure and education and some visibility around postpartum depression. And while that is wonderful, we also want to be inclusive to the fact that there are lots of other mental health conditions that may not be postpartum depression that could still be a mental health issue in that period. So, whether that's those anxiety disorders or other types of mood and adjustment disorders, or of course, more serious like PTSD and trauma in that way, that might be a little bit more severe, although those are all impactful to an individual's life and can vary in terms of severity as well. So, related to that, one thing that I'll also mention is, in addition to those changes like brain development and changes that accompany that perinatal period for that individual who is the pregnant parent or birthing person, there's some other risk factors that you want to think through and be aware of if you're working with this population or if you know somebody within this population. And some of those are related to risk factors like if this is an adolescent or teen pregnancy, they could be more at risk to develop some perinatal mood and anxiety disorders. If there is a prior abuse or prior trauma already within someone's history, you could be more likely to develop some of these perinatal mental health, mood, and anxiety disorder symptoms. And if there was something, for example, like sexual assault history in the past, you could be more likely to result in birth trauma or birth trauma symptoms related to that specific time period as well. And then, of course, if there's any untreated mental health conditions or disorders at that period in time, that could also put someone more at risk for perinatal complications as well. All right. So, in terms of the perinatal period, we have some considerations here on this slide, and some of the specific examples that I'll talk through related to some of the developmental milestones, brain development and growth, are going to be related to when you think about that first year after birth and pregnancy. So, within that time period, there are lots of things that occur during pregnancy related to brain development, nervous system growth, essentially all of those things that it takes to grow a fully functioning human. And so, that's why there are so many changes and shifts hormonally, physically to accommodate for that growth. What's also critical is that immediately after birth, you start from that 0 to 2 month phase, and that is critical for brain development. So, that young infant's brain is developing, making all of these connections, and really just growing into this great little being in terms of a brain development critical period. In terms of when we have more stable brain development and neurobiology, that typically is closer to around that 3-year mark, so that you're more out of the bulk of those progressive critical periods. So you want to think about postpartum care and perinatal mental health as a continuing journey with your clients that doesn't necessarily stop at a specific period, because they're going to have these other milestones as well related to their child. And so that helps with some of that holistic care and full being care for your clients, to keep those things in mind. One other thing that I will point out, if you are specifically working with the individual who is the birthing person, so the individual who has been pregnant or your pregnant person, at 18 months, that is typically the time when hormones stabilize for that specific period. So, some of that is due to chest feeding or breastfeeding, other different factors that occur, but that's around that 18-month period when you see that stabilization. So, you're still going to have a lot of fluctuation, which is normal up until that point in time. One example that I'll give that I pulled from someone who is a doula and birth educator, just to give context when we say there are shifts and changes in hormones and physical areas with relationship to pregnancy, is the hormone drop from day 0 to 3 postpartum is equivalent to taking 100 birth control pills per day and dropping to 0. So that is quite a large shift. So when I saw that specific example, I wanted to include that in today's presentation so that you guys could have that as well. Because while I know those are changes and we're very aware of that and often told about that, I don't know that we're told about the magnitude of that change. So that just kind of makes it a little bit more real in terms of support that your clients might need and what some of your clients could be going through at this time. Or even if that pregnant person is not your client, maybe you have a client who is the non birthing parent or a support person. Maybe it's another caregiver like a grandparent. And so all of these things can be helpful in those areas of scope as well. All right. So, in terms of scope, you have a few statistics here. And what I want us to really think through for today is that in some way, we are all connected to birthing individuals, child development in one way or another. So, whether that is school systems and planning, whether that's public health related concerns and considerations, whether that's workforce planning, whether that's schools and related areas, in some shape or form, legislative, politics, we're connected to many of these issues in one way or another, even if that's a little bit more indirect compared to a direct association that we're thinking about. And why I think that's so important for us to think through and realize within ourselves how are we connected to these issues is because just like many other issues, particularly in mental health, prevention is going to be the best case scenario for this as opposed to treatment. So we still want to have great treatment and services provided. And at the same time, if there's any ways in which we can be proactive or preventative in nature, we really want to do that and engage in those efforts as well. In terms of key context, this slide talks a little bit about some different statistics from one of the studies that I reference and will have on my reference page. So if you guys want to dig into that education a little bit more, I'm also going to talk just a little bit about the ACE studies. So for anyone who's not familiar with that, that is the Adverse Childhood Experience Studies. And many people reference that when they talk about trauma, when you talk about toxic stress, chronic issues that impact society, you'll often hear that ACE or Adverse Childhood Experiences study is more of a landmark study. But I also wanted to just make sure that individuals had that information as the high level, and we'll talk a little bit more about that. Also noting that from this slide, perinatal mental health, one of the things from a postpartum support international conference that they really highlighted as key is that this allows you to impact many generations at once. So that's why perinatal mental health work is so important, because you're impacting that child in a potentially preventative way, which is the hope and the goal to prevent some of these adverse childhood experiences. And you're also impacting whoever that birthing person or pregnant parent is, potentially support persons as well. So you're really impacting many generations at once, giving you lots of influence over outcomes and just support in general. So, in terms of some additional key context, here's that study that was referenced as well. And again, what's important to note is that anyone can experience perinatal mental health and anxiety disorders, and anyone can experience ACEs, so adverse childhood outcomes. The perinatal period can increase some of these risks depending on your risk factors that we talked about before. Some other factors would also be things like hormones, lack of sleep, complications. What does your recovery look like? What were some delivery considerations? As well as, what needs does the infant have? What about child needs? What about attachment, bonding, and supports? So, you want to think about all of those different factors as you're working with these individuals to incorporate both plans of care and plans for support. Hey, so, in terms of an activity, I wanted to give everybody the opportunity to give some feedback and to sit with some of this and to process what we've talked about so far. So, feel free to take just a few moments to reflect and type in the chat why you think positive attachments are important, and share, if you'd like, how you're connected to either early childhood and developmental impacts in the perinatal period, or if you'd rather share how you've either worked with this population or connected with that, that's fine too. Just to type that in the chat so that folks can learn from your perspectives and your experiences. I'll give you just a few moments to do that. Okay, we'll go ahead and work through some of that reflection time. If anyone's still typing in the chat or wants to type any of that information in the chat, that is completely fine to type that in as we go so that all can still see and learn from those comments and that we can integrate that into some discussion. Looks like so far in the chat, we're seeing more comments around healthy development of the child, connection between positive attachments early on and some esteem in life. So some self-esteem later on in life. I love those comments. Those early on attachments can build security for later on in life. So I think those are really great points to include there. Right, I'm going to switch us to the next slide. And within untreated PMADs, so untreated perinatal mood and anxiety disorders, these are some of the risk factors that we're going to talk through in just a moment. And before we get to risk factors, I wanted to call out specifically that as a new research area and population, individuals are being more inclusive to non birthing parents that I mentioned earlier. So many research studies you're going to see, they're going to use the term fathers as a new research population. And in terms of that research, it is really showing that they also can deal with some of the same perinatal mental health, mood, and anxiety disorders as the birthing parent, which that makes sense in some ways that they're also being supportive of their partner, the infant. So they're dealing with some of those other shifts of lack of sleep, potentially, lifestyle changes and adjustments, and other roles and functions related to being a parent or caring for both an infant and supporting an individual who's the birthing person. So, just wanted to remind everybody again, though, that perinatal mood and anxiety disorders don't discriminate against socioeconomic status and whether someone, is of a certain status or has, some different resources in that area. That doesn't mean that they're necessarily less likely to get a perinatal mood and anxiety disorder complication during this period of time. And so we want to think about those areas, even though there are some of those risk factors that we've seen. And while that's true that it doesn't discriminate necessarily with economic status, I did want to call out that a lot of research and conference sessions that you might go to on this topic will talk through some specific impacts related to certain populations, such as Black women in particular, who can be more at risk for certain medical complications and certain other mental health concerns as well that could go undiagnosed or untreated. That is something that research has shown specifically there when compared to other individuals of different racial or ethnic backgrounds. In terms of the risks of untreated PMADs that I mentioned, this comes specifically from a study done by Kindig in 2017. And so I wanted you guys to have some context for that, whether it's, on the medical end, whether it's some of those outcomes that we talked about that are similar to those adverse childhood experience outcomes related to health outcomes and data. So things like divorce, intimate partner violence, or some of those things related to medical care. And that medical care bullet is also more specific to what we were seeing with those statistics around individuals within the Black community were less likely to get some of the same medical care that could then in turn relate to increased either perinatal mood and anxiety disorders or increased medical complications from birth as well. So that's where some of those statistics come from. So, another study, just to give folks some context, was done by Windsor, and this was a study done in 2013. And this was more around United States mothers. And so, this gives you a prevalence of 21.9%. Again, that's just from this specific study. Other numbers vary a little bit. You will typically see that 1 in 5 statistic, though, for the most part, around perinatal mental health and anxiety disorders. This one specifically is talking about depression, and I went ahead and included that in here just because that's where so many folks are most familiar is with that postpartum depression category and depression amongst perinatal mood and anxiety disorders. What I think is important though is this last part related to of that 21.9%. What you can see is that of that 21.9%, so about 1 in 5 of individuals who are pregnant persons who experience this, that 66% of them, so that's the majority of individuals with the perinatal mental health and anxiety disorder in the perinatal period, had some kind of comorbid condition. So here they specifically gave the example of major depressive disorder and generalized anxiety. But I think that's really important because what I've seen too is that you may have someone who does get diagnosed with perhaps postpartum depression, and we want them to have those services. That's great that they get services and treatment for that. And they may also have some other things going on that might not be caught. So, whether that's related to PTSD and birth trauma that may not have been caught or screened for and assessed, or whether that's some of these other comorbid conditions like anxiety, that's pretty common too. And so, those are some things just to be aware of with this population specifically is how high of a percentage that comorbid rate is. So, most likely, if you're screening in for one thing with your client, it's possible at 66% rate that they have another. And those percentages are going to vary based on the research study that you look at. This was just one study that's considered more of a landmark study in that area. So I wanted to include it here for context. So, in terms of perinatal mental health and wellness, you want to think through, what are some of the factors that influence this, and what are some of the ways that we can promote what I like to call perinatal wellness? Perinatal wellness would really be mitigating impacts during that period related to perinatal mood and anxiety disorders. So, for this, you want to think about what are the other complications and factors that have occurred at that time, because those are going to be factors that influence either perinatal mood and anxiety disorders or the impact of those, and that can help you to promote wellness if you leverage some of those strengths or increase some supports in those areas, which is really critical with this population. Some of those considerations would be the type of birth experience, the type of recovery experience, the impact of supports and supportive individuals to help buffer some of those needs, and considerations like thinking through, everyone's birth and recovery is very different. And so you want to think about considerations, did we have some secondary issues? Maybe that's hemorrhaging or a lot of blood loss. Maybe there were some epidural issues or birth trauma. Maybe it's something related to, hey, this individual did not plan to have a C section, and they did end up having to have a C section, which is major surgery. Maybe it's related to some other type of complication throughout that process. It could also be something that isn't necessarily delivery related, which could be something related to chest feeding or breastfeeding and complications with that. Or some of those secondary infections that can come from chest feeding or breastfeeding, like things like mastitis, where you might get a rash, feel like you have the flu. Those are all things that can impact the overall wellness of someone during that perinatal period. So, we also want to be thinking through that as humans, everything is complex and complicated. And with that, you want to be aware of any of those pre existing mental health conditions or psychological issues, as that could impact some of the supports during this period. That could also include any pre existing medical conditions, disabilities, or other areas where we would want to offer just extra support or have a plan in place to help provide overall wellness in that specific area. In terms of how do we really help, we want to talk about the first area in which we can help and have an impact would be once we know about perinatal mental health, some of the things to look for, some of risks, prevalence, and considerations is we would want to think about overall screening. For Postpartum Support International, they have some recommendations on screenings, and so I'll share those with you. They recommend that individuals and pregnant persons are screened for perinatal mood and anxiety disorders at the first obstetrics visit. So, through your OBGYN, that pregnant person's OBGYN. And then they want to repeat those screenings during pregnancy at 6 months and then at 12 months when they follow up. In addition to that, they want to make sure that at pediatric visits, so from the pediatrician, that there are additional screens that would occur after birth and that initial birth visit to an OBGYN, where at 3 months, 9 months, and 12 months, that would occur at pediatric visits. And so the reason why they have both the OBGYN and pediatric visits is because for many birthing persons, once they go through that initial exam after birth, they then don't see that provider for another year. And they felt like, as a best practice recommendation, a year is a really long time in this specific period to miss those opportunities to screen and connect. So I would recommend that you check in with other care professionals who have access to your clients, whether that's through care coordination and collaboration as a best practice with your releases of information, or at least checking in with your client to make sure that they were screened, because different care providers implement these recommendations and have different levels of knowledge and understanding related to perinatal mental health and perinatal mental health topics. So that's one area where we can also just check in on that, because potentially someone has or has not been screened. And I also made a little note on this slide as well. When this talks about often we see a peak in rise of prevalence at 3 months after birth, there are a few different things that are potentially going on at this time period that you want to be aware of. So, one is if somebody was using FMLA or returning to work and they took the 12-week period, this would coincide with that return to work for birthing parents who are returning into the workforce. Some other key factors when you're thinking about infant development is you will often see that they start sleeping throughout the night, and by 3 or 4 months, you begin to hit what's called that infant sleep regression. So, if someone has been able to have a full night's sleep up until this period of time, and then the sleep progression hits right around 3 to 4 months. That can be really challenging. And if that is also the same time that an individual is returning back to work, if that's the situation for your client, then that can compound to they're returning back to work. That's a major life transition. We're having sleep regressions and we're not getting the rest that we're used to. And so that's a compounded impact that you could potentially see during this specific time period. So, in terms of screenings, I'm going to talk about two different screenings today. The reasons why I'm going to focus on these two specifically are because these have a lot of different areas where you can use different languages. They are public access that you can get, and you can utilize them with minimal need for scoring. It's fairly easy to score and to administer these measures. And so these are some common screens that we have. And one of those is the PHQ-9. So that is the Patient Health Questionnaire 9. There are different versions of this, but this is the specific version that we're going to talk about for perinatal mental health. And then you're also going to see, so the last link at the bottom is going to be the Edinburgh Postnatal Depression scoring scale. And so for that one is also a very well used screener. And we'll talk just a little bit more in detail about these. Okay, so for PHQ, what's nice about this one is this correlates to DSM diagnoses. And so if you're already familiar with that area of work, this might be a good choice for you to help overlap that if that's work that you're already doing or with another care provider. It has a range of uses. Again, many languages that I referenced as well. One thing that I would point out for both this and the other screener, though, as with any other screener that you might choose to use in your practice, would be to make sure that you're still using your clinical judgment. Because even though this is self reported, if you are seeing something that doesn't match what's being reported by a client, you can still put other services in place if possible or give additional referrals just in case that what someone is self-reporting, you're seeing something that's drastically different. So I would just always make that note as a clinician to use your clinical judgment and take in all the different types of information there, whereas these specifically are self-report measures. In terms of this Edinburgh postnatal depression scale, most often, I hear and see this one being used, which is more specific to depression, but it is easy to score. It's in many languages. I think part of the reason why this one is used more often than others is because it's also validated with other populations. So if you think about teens, if you think about fathers or those non birthing persons, you're able to utilize this screener as well, which makes it quite versatile for those individuals. And again, just made a note there for this one specifically, if somebody has a 9 or more or any suicidal ideation, you just want to have immediate follow up. Of course, with anything, whether you're doing, maybe another screener for suicidality or there's that immediate need for that, you would also want to reach out and do follow up for that as well, even though these are more specific to perinatal mental health and have those cutoff scores. So you would just want to read through those scoring areas and guides that are also included with those screeners as well to make sure that you're familiar with that before. Because another call out for this one specifically is that you're talking about within the past 7 days. So you'll just want to make sure that before you administer that to that client, that you've read back through those key areas and then given them that specific parameter for that screener to fill that out accurately. Okay, so in terms of screeners, one thing that I wanted to talk about that I think is not well screened or that I haven't heard quite as well screened for in the past is related to traumatic birth. So think of that as more related to the PTSD specific diagnosis related to this. This is kind of a new area of trauma research that has emerged, even potentially within the last decade. Some statistics around traumatic birth are around, so this one on the screen that you'll see is about 45% of births are traumatic. There's also some research, so it depends on the study and the specific research that you're looking at. Many numbers that you're going to see are 1 in 3. Many numbers that you're going to see are also going to be 1 in 4. So there's some slight variation there depending on what specific research you're looking at in terms of birth trauma. The consistency and agreement, though, is that if a mother thinks her birth was traumatic or a birthing person thinks their birth was traumatic, then it was traumatic. And these numbers reflect overall those individuals that were screened or assessed for birth trauma. You want to keep in mind that with any reported number, there's also likely a lot of individuals that may not get screened or that may not get assessed for this. And that may be an area that's overlooked if we're really focusing on postpartum depression and some of those other areas of work that are also really important for this population. So, again, thinking about things like PTSD, thinking about traumatic birth experiences. So, both whether that's the mother's life at risk, the baby's life at risk, maybe it's related to, this birthing plan that was presented or this idea of what that experience would look like. And then maybe there wasn't involvement or choice, or there was some emergency or crisis situation, and that drastically changed and resulted in a different experience. You could have some traumatic birth from that as well. That could include some of those complications that we talked about earlier, whether that's, intensive hemorrhaging, other complications. It could also be related to recovery, which is something that is a trend in area where I don't think we have a lot of research yet. So if you're really interested in this topic area and research, that would be a great area for you to add to the research literature is traumatic recovery. So things like, again, was that different complications? Was it secondary complications, diastasis recti within the abdomen of the birthing person, or just lots of different kind of adjustment factors there? All right. So, in terms of screening, being aware of these different areas, we want to think about screening is great, and that's one best practice standard that we have. However, if we just screen and we don't link people to resources, we miss a really important part of the equation. So, we also want to think about what is really truly best in terms of that linkage to services. And in terms of that, from a good, better, best, of course, we want to screen, but we also want to make sure that we're making referrals to appropriate professionals in that area based on whatever those needs may be. And even that we're checking in on how is that care going if that's not provided by us or our area of expertise. And that we are working with those care professionals if that's appropriate for your setting to give a collective and integrative team approach. These are just some different kind of ideas of how that could be included in help. It doesn't mean that you are limited to those specific ideas. Those are just some considerations to be aware of as you're thinking about referrals as well as collaboration with referrals and really checking in and following up as an absolute best yes for your clients. Okay. So, in terms of disability and where that connects, I did want to make sure that we spent some time on that so we can dig deeper into these experiences. And what I would also love to hear and see. So, in the chat, if you guys have had any experiences with individuals with disabilities who are working through the perinatal period, please feel free to put that in the chat or type that in the chat with how did you support them. And if you have not yet worked with an individual in the perinatal period with a disability, then if you think through how would you plan to support them and what would you do, feel free to type that in the chat as a reflective moment and a way that we can learn from each other. I'll give you just a few moments to reflect on that and type that in the chat. And while we've got some folks who might still be typing, that is fine to type that in the chat as you're able to. And we will move on to the next segment of our presentation so that we can also have more discussion time at the end for any of those feedback areas or questions that you have. So, in terms of the perinatal period and individuals with disability, you want to think about some of the, again, integrative care components. So, whether that is specific physical therapy, again, until I was really researching this area of focus and learning more about the perinatal period, I didn't know that there were so many specific providers that have targeted training in this area. And one example of that would be for physical therapy, they have pelvic floor physical therapy, which can be utilized during pregnancy and immediately after birth as someone who is trained specifically with relationship to this period. And that can really help the labor and delivery experience, that can help the pregnancy experience, and can also prevent some of the issues, birth complications, recovery complications that you could see if utilized before proactively. So, more on that preventative sphere as opposed to treatment. Now, it may also be needed for treatment after as well, which is good to get a checkup. For example, someone who has maybe some abdominal issues or something that has happened as a result of that. I mentioned before diastasis, or sometimes you'll hear what's called diastasis recti, which would be a stretching of that inner muscle within the stomach, which is common. But if that doesn't go back into place within normal limits, post delivery and that time period, that's when that can cause some complications. And so, pelvic floor physical therapy can help with that to get somebody back to hopefully as close to a normal functioning as they're able to before. That's going to depend on the severity of the issue, though, for each individual person, but that can greatly help. Again, remembering that prevention is better than treatment. Also, keeping in mind that a lot of these issues people don't talk about or don't want to talk about openly. So, I just want to also call out that you may experience either there's some stigma here or some cultural factors here around some of these issues. So, when we can approach it from a professional and educational supportive area as education on resources, sometimes that can be really helpful. Because the other thing that tends to happen is people think some of these issues that might be common are normal, but then you'll hear from an OBGYN or you'll hear from somebody who's specific to a physical therapist working with pelvic floor issues that some of those issues are actually not okay. And while it might be common, that's not normal and it can be treated or there's some intervention for that. So that's why it's really important too for that education and furthering your education even after today on all of these different areas because there's so much to learn. Other individuals who can be helpful would be prenatal fitness providers. So, making sure that you've got somebody who has that certification that can help and be preventative for lots of different issues. And also, if you have somebody that's trained in that area, you can mitigate any of those risks of, hey, are we doing the wrong thing that could be harmful or have some negative impacts there so that you get those positive health benefits of exercise, fitness, all those different things as is appropriate for each person. So, other individuals would be education around a doula or a midwife. So, when you think about your birth plan, how somebody wants to engage in that process, doulas and midwives can be used in addition to other medical professionals, even if it's just to give trainings on that experience for the birthing person, because some of the hospital trainings only focus on infant care and not so much care for that specific person going through those different stages of life at that time, but they can give you education on that. And they can also help to advocate for and help with postpartum care or even in that labor and delivery experience. Because one specific call out related to that is a lot of the mothers who experienced birth trauma said they either didn't feel like their voice was heard, they did not feel included in the process of making decisions, or there was some kind of loss of power in that specific situation. And having someone who is there, maybe that's a support person or a caregiver, maybe it's not a formal professional, but maybe it is a doula, maybe it is a midwife, maybe it's someone else that's kind of a patient advocate that's there for that process, that can be that person to step in and help empower and advocate, can buffer a lot of those things and help to have a more positive experience, which is what we want, because we want people to have the most positive experience with that they can, as opposed to all of those elements that are going to increase cortisol, increase stress hormones for both the birthing person and that infant, as well as individuals who might be a support person. All right. Okay. So here's some examples of perinatal mental health and disability. And it looks like you guys have typed in the chat too, that different students have asked questions about pregnancy and disability, or clients considering pregnancy and disability. So, the impacts that that disability would have on their life and their experience. Those are great answers. Thank you for typing those in the chat and engaging. And thank you for thinking about what impacts would this have, because we want to be aware of those things so that we can plan for supports, and so that, again, we can make that the most positive experience with possible. So these are just some examples. This is not an all-inclusive list, but those themes of independence, those themes of empowerment, themes of voice and choice that are really important to a lot of people, that can come up when you're talking about specific individuals with disability or different limitations with ADLs or self-sufficiency, that we can work through and think about how can we help put that best care in place so that they can have as much independence and choice as possible during that time period. Okay. So, here are some statistics on the disability impacts related to this. Most of this was pulled from the CDC, so specific to the disability impacts section of that. And you want to think through other areas of consideration as they relate to disability. For example, you could have gestational diabetes in pregnancy, whereas maybe an individual doesn't have diabetes. Other than that, it's just specifically gestational diabetes. It's for a period of time. You could have other disability hallmarks or limitations. So, whether that's things like a mobility issue or certain conditions that could appear during pregnancy, we want to be aware of that from a disability standpoint. And we also want to be aware of what are those other things that might not be a disability per se, but they really impact more of a life stressor type of impact for our clients. So things like, is it childcare? Is it lifestyle changes? One thing that has come up so much within the last few years that I've heard about is quality childcare and access to childcare. So whether that's individuals who are going to use their family as childcare, or maybe we're not planning to return to work and either needed to return to work due to economic issues, inflation, something related to kind of a financial consideration, and then also a childcare area issue of, we saw during COVID a lot of childcare centers closed down. Some didn't come back or open back up. And so we want to be mindful of what resources do individuals have? How can we try to best work with them and support them to get resources? And what is their experience like for this process? So, being that supportive voice. In addition to those statistics that were on the slide before, I wanted you guys to have just a general understanding of some perinatal legislation. So that relates to ARCA specifically on that public policy work group and committee. But it's also just important for you guys to know and have some of these things in your back pocket as resources as well for clients. So for this first one, where it says EEOC, that is the Equal Employment Opportunity Commission. So that's what that is related to. It's from the Equal Employment Opportunity Commission. And in addition to these key areas, which are important pieces of legislation, we also want to think about the discrimination factor of hiring and recruiting. We also have some standards in place to say you would want to discriminate against an individual or an applicant in the hiring process due to their pregnancy status or even due to their family status as well. So being mindful of that. And we'll talk a little bit more about some specifics related to these as well. But that EEOC measure that's mostly related to ADA, you guys are probably most familiar with when you think about disability for this population. Think about what specific disability areas might need accommodation for this period of time, because that may be something that your clients aren't thinking about. They could be eligible for an accommodation that could help them in the long term, and that could be language that they just haven't used before or haven't thought about that. So that's an area where I think rehabilitation counselors are well positioned to help a lot in this area, and that's an area that we don't talk about often. So I wanted to make sure that was clear for this webinar, that you guys probably have more familiarity with this than other providers, other caregivers, support individuals, the general population, and even mental health professionals in general. A lot of people just aren't really aware of ADA and accommodations, what that looks like. In terms of that, these are some specific areas that I wanted to call out. We are going to get to a slide on parental leave just to give you some high level context of these areas. But what's important about this first one, so FMLA, that is the Family Medical Leave Act, that's a federal standard that does give an individual 12 weeks of protected time to come back to work. What's important though is that does not mean paid time. So I put some links and some information below that. That means that that time is protected to come back to work, but that does not actually mean that that individual is receiving time that's paid by that company. So some companies, that's going to vary. Some people will give you sick time, vacation time, and you can use that. Some companies will give you some time, but at the federal level, it is not mandated that that is paid time specifically. You'll also see below that this FLSA. That is the Fair Labor and Standards Act. So that's more around that chest feeding, breastfeeding parameter for the health of the birthing person and the infant, to guarantee time to be able to pump at work, to have a designated area to pump or to breastfeed, and to take a break to be able to do that breastfeeding, chest feeding, pumping mechanism. So giving some of those protections to workers. Now, when I mentioned the 12 weeks not paid, so at the federal level in America, you can see just based on this, we put these in order of the weeks granted for legislation. In America is at a 0. So that means 0 weeks paid is what's mandated for that specific parental leave time period. You can see Britain's got 39 weeks, Japan there with 52, Estonia 82, Sweden 68. So different countries and different cultures are going to have some different experiences with parental leave and with resources. So if you ever work with clients of different backgrounds, maybe they come from one of these other countries or regions, you're going to want to think about how does that culture and impact compare to what they're seeing and experiencing now within the American healthcare system and political system, as well as other factors related to their culture as well. So those are just some things to think about, and I wanted to give you guys some context for kind of where does that fall, where does that intersect in terms of that wellness perspective. So in terms of that, we have talked a little bit about just other providers. What would we recommend? What would we do? One note specifically here is that there are individuals who are trained in perinatal mental health. So whether it's a perinatal mental health certified provider, the PSI website, so that Postpartum Support International website, has a list of providers who are trained and credentialed. If you feel that your clients needs that specifically, they'll also have on that website a list of support groups, resources, community connection activities, and things for each area that are important. And you want to think about, again, the advocacy for accommodations, legislation, whether that's, some of those other specific providers that we've talked about and mentioned today. And one bullet that I want to talk a little bit more about here is related to psychiatry. So, when you talk about perinatal mood and anxiety disorders, The medication side of that treatment option would be typically a psychiatric nurse practitioner or a psychiatrist. Now, not all of those individuals are comfortable prescribing, particularly to an individual who is pregnant. And so, what you're going to see, this is just an ethics flag for everyone to be aware of. You will see during this particular period, many OBGYNs or routine providers will be prescribing psychiatric medications in this time period. Most often, that is due to a psychiatrist or other care provider who typically prescribes those medications, saying, hey, I think we should stop medications at this time. Maybe we should titrate down, or I'm not comfortable prescribing these types of medications during the pregnancy period. We need to refer you to an OB. And so that often is why you will see more of an OBGYN prescribing those specific medications for this time period, because it's sometimes it is appropriate to titrate down or stop a certain medication during pregnancy and the perinatal period. At other times, that may not be the best choice for that client, and we have to weigh the risks of that. And so someone who's trained in perinatal mental health can help. The other tool in our toolkit that we can use is Postpartum Support International has a psychiatric help line where psychiatrists can call in and get a consultation with someone trained in that specific aspect of work to help say, okay, what are the risks and benefits of this medication? Because it may be that it's more beneficial to remain on that medication and not have a spike in mental health issues or concerns that could be very serious or have adverse negative impacts for both the client, so that person who's a pregnant person, but also from that child as well. So I wanted to mention that and call that out because that may be individuals who are not specifically trained in perinatal mental health, but that could be supporting individuals during that time. Okay, so some other things that I like to think about are things for leaders. So this is leaders regardless of your role. This could be you're a professor, you're an employer. Maybe you are someone who is on a board, on an association. You're a leader in your community. You're a leader in your church. You're a leader in other ways. There are many different ways to lead. And when you facilitate inclusive and collaborative approaches, you address these issues, this is also a really great way to support the specific area of work. And what it does is it facilitates trust, longevity, and it really helps make sure that we have resources in place for some of these key areas. And some of this can just be so, like one bullet as an example, ideas for leaders is, if you're in whether that's an employment situation, maybe you're on a board or something else, and individuals typically have a certain workload and tasks. Can we be flexible with work hours or be more task based as opposed to hourly based for some individuals, either in this period or as they adjust to life with a young child or infant in that period? Maybe that is related to cross training. So, making sure one thing I like to do for myself leading a department is that we have ideally at least three people who know enough about a position or role that if somebody is out, if somebody is sick, if somebody is ill, if something happens to someone, that somebody else has enough knowledge to either pop in and help cover that, to help provide as a backup for whatever that item or task is, or to help train somebody new if we were to have a transition. Practices like that can really help individuals feel empowered to take their leave time, not rush back to work. It can also help individuals know, hey, I can take a pause or a reset or a wellness break if needed because somebody else can help to fill in, or this work can be paused at that time. So, those are just some considerations there. I've put a few more considerations here, particularly around prioritizing, what are the most important tasks for that specific role? And you, as a leader, helping them to say, hey, we did what was most important. We kept things that are most important, most important. We put the first things first. So, whether that's cross training, load sharing, also, one thing that I like to project out is a little bit of buffer, whether that's a board position, whether that's for your students being aware of capacity and mental health, whether that's for yourself, for your clients, is whatever roles you have, think about you want to have a little bit of buffer time in case you do need a break for some wellness, for some self-care, for some sickness, for some illness, and also some buffer time of things are not always going to go to plan. So if we have some buffer time built in and we're really adept at prioritizing what's most important, that can help buffer some of those other times as well. So, those are just a few ideas that can potentially help there, as well as encouraging that parental leave, encouraging accommodations. There's also some really simple free ideas like if you're inclusive in your approaches, whether that's maybe you do something virtual instead of in person, so people don't have to travel away from their families or leave a new young child or travel in, a specific period of pregnancy where they're not comfortable traveling. That virtual option could be more inclusive. Maybe it's that you record. So, whether that's you're recording a training or a meeting so that someone can view it later, maybe they're viewing meeting notes, maybe some things are optional. Those are all approaches that can really help parents and pregnant persons have better access and be long term successful in certain areas within the community and still be productive. Is if we're really thoughtful in what approaches we use, what learning styles and mechanisms we use with those areas to be inclusive. The neat thing about that is that's also really helpful for a lot of individuals with disabilities as well. The more inclusive, the more that you produce autonomy, that's really better in general. In terms of those practical examples, some of these I mentioned. So, being open, being flexible. Some examples for my own team is I had an individual who really wanted to come for some in person retreat items. And she had a young child and made the choice to say, I'm going to go and come to this and I'm going to bring that child with me. And I have a support person that's able to come with me and stay at the hotel so I can go to the team events, but then I can also still have this time to have with my family and not leave them. That option worked for that specific person. Always be mindful of that personal situation and their individual autonomy because that example is not going to work for everybody, but for some and for that specific person, that's really what they wanted. Another individual on the team really appreciated and liked certain team events being family friendly, certain team events being optional. And so the ones that were more family friendly, they went, they were able to bring their baby, they got a lot of support, they were able to have lots of caregivers that they trusted in a respectful way there at that event. And so for them, that was a win win. So those are different options and examples that represent different individual choices. But again, the more that we can be inclusive and flexible there, the better. So this just gives some more practical examples for Postpartum Support International, and I did see that in the chat. Yes, there is a line where physicians can call to talk about medications and get that support. It is on their website, and it is called the psychiatric line. So that's the psychiatric provider consultation line on Postpartum Support International. And one thing that I actually already had on this slide is how inclusive their conference was. When I went to the Postpartum Support International's conference, when I say that's the most inclusive conference I've ever been to, they had lots and lots of young children, infants. So you could see lots of individuals kind of wearing their babies. That was integrated into sessions, that was normalized. Like it was a part of life that you are a parent and a caregiver. And so we're inclusive to that. There were lots of different stations to check in, whether that was chest feeding, pumping, feeding, what have you, for individual infant care. There was inclusion with support persons. So that was a conference where a lot of people were actually able to go and bring like a support person, or maybe, they had different spaces where support persons could stay at the hotel while somebody else went to a conference session. And so it's even ideas like that that really foster inclusion for this population that can be important and be key. I'll also leave you with Harvard Business Review, Forbes, John Maxwell, industry leaders in leadership and employee engagement and retention. They really talk about valuing employees, connecting to individuals and people as people first, and that individualization and the acknowledgement of individual differences can lead to higher satisfaction and better retention. And so all of those things are really important when you think about that work. Okay, so here's some key resources that you guys may want to have available, have in your toolkit. Most are familiar with this first one. So, the National Suicide Hotline, this could come up when you're screening for perinatal mood and anxiety disorders. This could come up in your sessions in advocacy anyways. And so just want you guys to have that. The shortened version of that is just that 988. So that's great to be able to call, to be able to text, to get some support if that is a specific issue that you need resources for one of your clients, for yourself, for family, friends. Just always good to have that top of mind. 988, let's get some resources. Here, also below that, is the PSI helpline. So that's Postpartum Support International. And they have both English and Spanish currently in terms of helplines that you can call and get access to consultation, support, resources, and basic information. Also, they do have a specific care provider line that was asked about in the chat that's for psychiatric providers. That's on their website as well. So that is a great addition and call out that you may want to use. Okay, so as we start to wrap up more of this piece of the presentation to go into questions, answer, discussion, and follow up, I want you guys to really think about these are some key areas where you can have impact, where you can have elevation of voice, where you can really use rehabilitation perspectives, disability integration to make impact for clients. And with that, this was an overview of many different perinatal topics. There are so many more topics that we did not touch on today related to this. So, specific manifestations of those perinatal mood and anxiety disorders. We did not really talk through specifics around infertility, pregnancy loss, infant loss, more of the grief loss components and reminders as a specialty subset. We didn't talk through some of those areas related to increased risks if you have a child or infant who's got a lot of medical conditions or disability status. If you have lots of different areas where you want to think through, okay, birth of multiples could impact and increase your risk for perinatal mood and anxiety disorders. So, those are some specialty topics. If there's one that you're particularly interested in, one will have my contact information at the end. Two, we're going to have QA discussion. And three, if as this evaluation was typed in the chat here, if there's a specific area where you want another area of focus or a different training around a specific issue, if you can type in what specifically would be helpful, Daniel can get that to me and I can look at that if that's something that you guys would like as well. So here's some of my contact information and what I can do. Somebody did ask about the slides as well, is I can send all of that information to Daniel, and then people who have registered, we can make sure that you guys get that as well for some of those slides and notes. And so there's that CE link too. And then we're going to go into some questions and answers. But I also wanted to give you guys some of these were just some of the references that I used. Now there's a ton more references from PSI in their 2-day training. So if anyone ever is interested in certification, you can get certified in perinatal mental health. You'll go to a full 2-day training through PSI. You would get to do some elective trainings that you choose. You would take a certification exam, so kind of like a licensure or CRC exam. It's pretty equivalent. And you would get their really large training guides to go through those 2-day trainings. And there's a lot of good information in there that we couldn't fit into today's training, but those are some really great resources to have. And so one thing that I'll do is stop sharing that so that we can get back to our main chat and questions and answers here if you guys have them.
Well, first and foremost, Dr. Lemmons, thank you so incredibly much for such an informative and wonderful and really important webinar. So thank you for sharing your expertise and knowledge and just so many wonderful resources. So we do have a few questions that have come into the chat box, and one of them being, did I understand correctly that perinatal depression in a parent or caregiver can be related to lack of or delayed brain development of the baby? That
Oh,
was
that's a great question. So that can result in some negative impacts later on throughout childhood and some adverse childhood experiences later on. Now, that's going to depend specifically for what happens within that brain development, what happens in utero to that. So I wouldn't say that necessarily that's going to create or cause that, but that's an issue that you could absolutely check and see, did that drive some of that, or did that contribute to that specific issue? That's a really great question.
Thank you, Dr. Lemmons. There was another question um, expressing appreciation for your use of inclusive language. The question then from there was, I've also heard gestational parent and non-gestational parent. Are those terms considered inclusive as well?
Yes, those terms can be inclusive as well. And those terms would be, when you think about inclusivity, they're going to be more inclusive than traditional terms like pregnant woman or father, dad. That's going to be more inclusive there. And the inclusivity around the parenting language is going to be more based on a role. So, more on, are you actually in that parenting caregiver role? So, that's a really great call out. Thank you for adding that. Yeah.
Thank you. Another question, Dr. Lemmons, that had come in is, what are some common misconceptions or stigmas that you've encountered surrounding perinatal mental health and disability?
That's such a great question. I think a lot of it is related to thinking that some things related to perinatal mental health, or especially pregnancy in general, again, are normal. And not realizing, oh, hey, this was actually a complication and just something that we don't talk about or provide a lot of information in society on. So, for example, it's normal to have what they call baby blues and to have some fluctuations, some sadness, some of those things. But there's some stigma still in mental health and talking about depression or talking about specifically role changes. So there's a strong stigma and belief or kind of faulty conception that some people have around, okay, I'm going to go back to my life exactly as it was. And this is not going to be a really impactful event. Like, we're going to have a baby, we're going to put this in place, this is what's going to happen. And I think there's just a fallacy in how many changes occur throughout that period for a lot of people that leads to a lack of preparedness in some of those issues. And so some of that's kind of our own lens and filter around what we're expecting or what we've been told about that time period. And then some of the realities, both medically and then life changing wise of that. So, one example is, where it's really hard to capture in words what it is like to go from not being a parent to being a parent. And while that may seem pretty simple and clear cut, there's so much to that where once you are responsible for someone else, another being, everything changes because you never again will go into a time period where you're not a parent in general. And so just the role strain or mental stress of that can be a lot for individuals as well. So that's a common misconception. Other common misconceptions are that, if for some people experiencing pregnancy issues related to infertility, miscarriage, there's faulty assumptions around like it was someone's fault, someone did something wrong, when actually a lot of pregnancies result in a miscarriage or other issues. And it was not due to something that someone did or did not do. That was just part of that body's process. And those individuals do not have to feel shame about those issues because there was nothing that they could have done. And I think because sometimes those things are not talked about a lot of individuals feel a lot of mental health stigma and a lot of shame around things, whereas there are also just potentially things that happen that we don't have control of. So there's also some misconception to that, or even what I hear more from couples is, well, we thought it would be easier to get pregnant, or we didn't know infertility was a thing, or secondary infertility being a thing, which is a whole nother presentation topic around, someone who was able to get pregnant easily the first time, but then when trying for multiple children after their secondary infertility. So those are just some of the general high level misconceptions that I've either heard or topic issues with stigma that could also tie into kind of a factor myth situation.
Thank you for that. It looks like there's also a comment in the chat box mentioning I'm still stunned by the example you gave related to hormone levels. 100 birth control pills one day and 0 the next. Holy buckets. Yeah, it's very staggering.
It clearly got my attention enough to add it in the presentation when it was there. And that's why I think it's so important to continue to increase our knowledge in that area because again that came from a doula and birth educator, and I had gone through all these perinatal trainings and hadn't heard that specific example before. So I really appreciate that some people are putting that information more out there in the public arena and different channels to really encourage conversation around these topics.
Absolutely. And we do have one more question, Dr. Lemmons, and this is kind of in the work that you've done and among your fellow colleagues within this particular area of the field. Have you or your colleagues encountered difficulties that you've heard from clients as it relates to challenges with medical providers in terms of treatment towards your clients within the realm of perinatal mental health and particularly with those clients with disabilities? And kind of what would be the role for the mental health provider to help with advocacy and re-education of those medical providers?
Yeah, that is such a great question. The short answer is yes. Within the medical field, just like other fields, you may have bias or certain providers who are more trauma informed than others. And when we typically see issues arise around certain providers, it's that they did not have training in perinatal mental health, and maybe they don't have a lot of mental health education and training in general. So they're not typically as trauma informed. And so that's when you start to see a lot of traumatic birth um, related issues and PTSD symptoms around they didn't involve me. I wasn't given a choice. My provider did this. Lots of kind of medical issues related to birth trauma that crop up. Now, that can also occur just in regular appointments, whether that's somebody's LGBTQ and they are going to a provider who's not using inclusive terms, perhaps. Maybe it's a different type of family situation. So maybe there's a surrogate, maybe there's this birthing person, and then there's other individuals who are going to be the caregivers for an individual and an infant. And those different dynamics, if we don't have providers who are both inclusive and educated on those areas, you run the risk for either discrimination or just a lack of trauma informed care. And so we do see that a lot in that community. So that's one, a very fair question. That's also come up more as it relates to a lot of Black women who have reported not being heard by certain providers and also represented in data and statistics related to some increased negative health outcomes as it relates to those individuals of color as well. And so there's both this experience that we hear about, and then there's both this research that's coming out that is supporting, hey, certain individuals in certain communities may either not be represented or have quality access to services or trauma informed care. One thing that was somewhat shocking to me is that a lot of people just don't have education on these things. Like I had a misconception myself before learning about this work that many OBGYNs were really well versed in these issues and would know to check for like very specific things postpartum. And then realizing, hey, actually, that's why we need to get a pelvic floor physical therapist involved or someone related to perinatal mental health to specialize in those areas, I think is something that even I myself have learned and have to be aware of too within this work. So, great question.
Thank you so very much, Dr. Lemmons. And at this point, we would again like to just provide our sincerest gratitude and appreciation to you, to Dr. Rebekah Lemmons, for this wonderful and meaningful presentation on perinatal mental health and disability. Dr. Lemmons, we're most grateful for you for taking the time to share with us today. And for those in attendance, we also appreciate you joining us today, and we would like to invite you to our next webinar as part of our month-long June 2024 webinar series, which is scheduled for today, Friday, June 7th, 2024, from 12 p.m. to 1:30 p.m. Eastern Time. And that will be Disability at the Intersection, Disability, LGBTQIA plus Pride, Identity, and Service. For those of you who have already registered, you can stay in this very Zoom meeting link. We'll just put you in the waiting room, and then we'll meet back here at 12 p.m. Eastern Time. And please be sure to review our month-long June 2024 webinar series program to sign up for our remaining webinars each Friday of this month. More information about those programs can be found in the chat box, and we hope that you'll consider joining us.